So you've heard from people who can say it much better and much more articulately than I can. These are the family members that I work with every day, the direct care workers that I work with every day who do not get the recognition that they need and really do the heavy lifting in the care of older adults in this country. So we need to do something to preserve this type of care, and we know that this is a very tough economic time, and we don't want to be greedy, although we would love to be greedy. We think that we want to at least maintain funding where it is now for Title VII and Title VIII programs. We think that with the increasing demographics, that this is an important thing to look at. And so we're looking at the Senate Appropriation Committee's recommendation that funding should be at least flat at $33.67 million for Title VII and $4.538 million for Title VIII. We are also asking for funding for all of those programs that are there. We know that some of them have been passed without funding. They're not yet implemented. You've heard a little bit about how important they are. Although these numbers are huge to me, I know they're not very big in the scheme of things in terms of our budget, and it's very important that they at least stay flat. We think that Medicaid needs to be preserved, and that is a huge issue, and I know that that's something that's up for a lot of discussion, but we know that cuts to Medicaid will have direct impact on jobs, and it will have a direct impact on the quality of care that older adults get. Medicaid is the primary funder for long-term care in our country. And it's not just for physicians. It also impacts nurses, social workers, direct care workers, so many millions of people who are taking care of older adults at very, very small amounts of money. This is a job that has been driven by passion and the heart for the job, but we can't really neglect the realities of the job is that people need a livable wage when they're providing this care. And any cuts to Medicaid puts that in jeopardy, so that we'll get a double whammy. We'll lose jobs, and we'll also affect the quality of care that we all want to get when we get older. One thing that we all have in common is that at one point we'll be a patient. The other thing we'll have in common is that we'll all get older, and considering the alternative, I think most people choose getting older. We want to look at funding for the National Healthcare Workforce Commission. This is only $3 million in funding, and it's included in the Senate Appropriations Bill. We think that it's very important. Again, $3 million is a huge amount of money to me, but I know in the scheme of things, this is not a lot of money to help preserve something that's so important in terms of our elder care workforce. We want to look at the Older Americans Act, which provides vital support to our nation's elders. It ensures adequate funding for existing programs. That's very important in this time of increased demand. And I don't want to forget the support for Caring for Aging in American Act, and this one is really a very easy ask. It's bipartisan, and it has no cost. So I think that should be very easy for people to want to sign on to. This bill codifies into law the loan forgiveness for health professionals who pursue geriatrics and gerontology training. And we just need to have that codified, that wording for geriatrics and gerontology, so that it would include members of the healthcare team who are using this as a career. And as I mentioned, there's no cost. It just needs some language, which we're very happy to assist with. So those are our asks. They're very modest. We're very cognizant of the economic times and the situations we're living in, but we hope that we don't use this opportunity to turn our backs on the care that so many Americans and so many people that we care for really need in this country. And with that, I think I'll conclude, and I'm very happy to answer any questions that you might have. Go ahead.
It's a statement and a question. First, my 11 years on the Hill, was so glad I'm happy to come to a briefing where two people outline really specifically what home caregiving is all about. Having gone through 7 years of that with my mom, both of you laid out exactly specifically what is involved every step of the process. A lot of people think caregiving sometimes is feeding your mom or your dad or somebody and maybe driving someplace or talking to them sitting next. No, it's a whole host of things, from toileting, brushing the teeth, to knowing how to lift them up, and so forth. The two things that we have learned in our family was that, oh, and by the way, with our family, we could have gamed the system on Medicaid, and Medicaid and the public and all taxpayers take care of my mom, but we didn't. We put our money together, and except for the last 3 years, we hired somebody to assist us. But during a 10-year period, I helped with 7 years, the critical period, but during the 10-year period, we all pulled together and learned how to caregive, the real caregiving, not just hanging out with your parents. But what we learned was very critical. One, are those direct caregivers. They're not paid enough. And they do have a right to be perhaps unionized or at least be put into law, codified into law that they would have at least a livable wage rather than a minimum wage. And then secondly, too, is what we have noticed in our system. I'm from the state of Hawaii. We have a great system in the state of Hawaii, but still, what was lacking was there's a lot of money that goes to training people in the clinical sense, doctors, the social workers, and so forth. But where there's a really lack of emphasis is on the ground. You know, like in a war, you have a lot of foot soldiers who get paid the grunt pay, and then you have the generals who get paid the billion-dollar retirement plans. Okay, well, that's how our family had likened after our 10-year experience. The same thing with caregiving is the people on the ground, the caregivers that we hire, and the agency takes part of the fee. They need to be better, well paid, and not only that, those direct frontline people who are not, how you say, educated in the sense of a 2-year background, a 2-year AA degree at a community college in caregiving. But we need to train them and also family members in like a 3 to 5 day crash course on how to lift a patient, how to brush teeth, how to toilet a person, how to bathe, how to comb your hair, how to take them out of the bed. You know, it was brought up that toileting the person every 4 hours. You know, we did that with our mom, so it was expected. So it was a very good technique to get into the habit of a lot of this. Sitting on the piano, she couldn't even play the guitar, but we get her fingers so she could exercise, massaging her feet, all of those kind of things. But again, well, we learned that we got to get down and filter more money towards training of those people who actually do the job, and then also increase their salary.
Those are very important points, and I know we do a lot of training for family members who are doing things that nurses are doing with 30 years of experience, only because we have no options, and this is what is needed to help take care of that person at home. And there is no formal programming for that. So those are all very good points.
Although we're in Washington, D.C., where you would think there are incredible numbers of resources and people, it's really a very small community of people who work in geriatrics, gerontology. That's why nurses who commit to that, or physicians, other people, they're in it for a long time because they may move organization to organization, but they're in it for the long haul. The nurse that I mentioned, who had been in the GEC and then helped us with the Master Faculty Scholars, is not an unusual person. We tend to use them and keep engaging them in our programs. She also taught in she works with the GSEP program right now because palliative and end-of-life care is part of what we're trying to integrate in that. we keep them not only teaching, but then engaging them. We've gotten other money at times for quality improvement projects, like with advanced care planning, with, again, falls is just a big issue. So we kind of keep weaving them in and out. We hope to keep building a stronger network of people who provide care, but they're also people who lead in this community to keep building the capacity for providing good geriatric and gerontology care. Does that kind of answer? We keep weaving them in and out, all these different programs, both to engage them and keep them going with us, but also to give them more leadership opportunities that feed back into their organizations.
I have a question about the Geriatric Academic Career Award, which I believe you mentioned is now actually available to disciplines beyond medicine. So it can be another of those sort of lever ways of bringing people together. But as I understand it, there's only enough money in it so that you can select one cohort, every 5 years, is it, or every 3 years? You can't actually have new people coming in every year. Those people have to wait for the current awardees to finish. Mm-hmm. So it's very off and on. I don't know if people could comment on how that impacts the ability of the program really to build cadre, and maybe people at academic institutions could comment on whether they actually have people who could fill those slots if there were more slots in the area.
I can explain, I guess, the dynamic, and then you all maybe can describe. The issue is that since the funding has been at the same level for several years, awards are made, and they're 5-year awards, and so all the funding is tied up for those 5 years and continuing those. So and I think all the geriatric programs are actually in that same situation where their funding has been flat for several years. So that's the dynamic that he's referring to.
So I think this is kind of a fate, a little bit of a fatal thing that happened, is that initially they were being offered kind of every year, and then there was a suspension of it at one point, and so that everybody started at the same time. So now everybody has to finish at the same time unless somebody leaves the program or et cetera, but they don't